Hello, everyone, and welcome to Health Gorilla's first session of HLTH 2023. I'm here with my colleague, Dr. Stephen Lane, who is the Chief Medical Officer here at Health Gorilla. My name is Dave Cassel. I am the Chief Customer Officer, and we are here today to talk TEFCA, the Trusted Exchange Framework and Common Agreements. There's a very obvious question one might ask first when presented with that session title, which is, what on earth is TEFCA and why should I care? Stephen, do you want to comment on that?
I'm happy to jump in, Dave. So Dave and I go way back. We've been working together in the interoperability space for the better part of the past decade or so. And much of what we did before we came to Health Gorilla was to stand up the current data exchange framework that exists for the country today. And that allows networks to connect to one another and exchange data. And it's been very successful. There are now billions of transactions going across the existing data exchange framework across the U.S. And the growth has been continuous in that. But what we know is that the vast majority of that exchange is for treatment purposes. This is providers leveraging their EHRs to exchange data with one another to support the treatment of patients. And that's wonderful. Before we had that, life sucked for us providers. It was very difficult to get the data that you needed, and now that is much easier. It's not perfect, but a lot of progress has been made. But a few years back, at the end of the Obama administration, Congress decided that that wasn't enough, that we weren't moving fast enough in terms of closing the gaps of interoperability, that there were still a lot of stakeholders that could not get clinical data, that while providers were getting the data they needed for treatment in many situations, the challenges of patients getting their data, of public health data exchange, of exchange with payers, and many other use cases really weren't moving ahead because there wasn't a great business model for that. So what Congress did when they passed the 21st Century Cures Act was they said that the HHS would need to either identify a trusted exchange framework and develop a common agreement, or just start from scratch. So the decision was to start over, to build a new trusted exchange framework for the country, building on the success of the exchange that's going on today, building on a lot of the same standards, really developing a new set of protocols, raising the bar with regard to security of the data, developing a trust framework that can scale across multiple use cases that we'll talk about as we go on, and really meet the needs of the broader community to support interoperability.
So I wanted to react to a couple of things there. First of all, Stephen's completely correct in how he's describing the evolution. I would add a few things into what he had said. One being the role of the federal government in incentivizing and generally helping to advance the TEFCA is definitely a level above what I've seen previously. What I've seen previously, and I'm hearkening back here for those who don't know me, and I realize we didn't really introduce ourselves in particular other than our current roles at Health Gorilla, but I spent 6 years as the founding executive director at the Care Equality Interoperability Framework, which is a private sector version, really, of what the TEFCA is meant to be. And at Care Equality and my counterparts at the eHealth Exchange, at Commonwealth, and these other existing interoperability initiatives, I think always found that federal stakeholders and then government at all levels, I think in part because of the lead that was being set by the feds, hesitated, hung back, did not participate in those private sector initiatives in general. You know, there obviously are a few exceptions there, but generally speaking, the feds simply did not get behind any of those initial initiatives. I think some of it was because of some market dynamics that occurred early in the decade of the 2010s, as there was a selection for a system by the Department of Defense that was looking for an EHR, and there was a lot of competitive rhetoric that clouded the field. And I think in part because of that, I think federal agencies felt that there were commercial interests that they didn't fully understand, didn't want to pick winners, didn't really want to get behind any of those existing initiatives. And so that was part of why the TEFCA is out there. Stephen mentioned that it was a decision to start from scratch. I think that is kind of a fair characterization, although at the same time, the entity that was chosen as the recognized coordinating entity that operates TEFCA is the Sequoia Project, same organization that provides the support for the Care Equality Initiative and for the eHealth Exchange, and in general is very well known in the space. And in particular, because the Care Equality Framework was there for them to borrow from, they've done exactly that. Not that there aren't differences from what the Care Equality Framework has done in TEFCA, but there is an awful lot that is similar as well.
I think one of the things that's similar that's worth noting is that when TEFCA begins, which we anticipate will be before the end of this year, it will be primarily focused on the treatment use case. It will really fill the same role that Care Equality is filling today, but there will also be the addition of the individual access service or patient access, which will be a new use case, which we really haven't been able to get off the ground in a substantial way within Care Equality. As Dave said, we were both very much involved in the early days of Care Equality. I think it was one of my patients that was the first exchanged data on that framework some years back. So that was a lot of fun getting that up and running.
And this seems to have worked. Okay, good. As I recall, it was the Friday right before July 4th of 2016.
Sounds right.
Yeah, and Stephen either called me or texted me, I don't remember which, but said, hey, I just pulled a patient from a practice that used the Athena Health EMR into my Epic instance, and it worked. And that was the first transaction on the Care Equality Framework. And you know, we've gone from there to today Care Equality supports something like, actually, Health Gorilla alone, I think, has millions of transactions in any given day, and obviously the other participants are transacting a great deal as well. So it's been pretty amazing to see. At the same time, you know, we could sort of keep coming back to this, but as Stephen said a little bit earlier, there were still limitations. There is still that limitation to the treatment purpose, and there are still organizations that do not participate. So the TEFCA really aims to bring in that remaining 26% is the estimate, or am I getting that one right?
That's on the office-based providers, roughly.
Yeah, of providers that are currently still not connected. But then, with no disrespect to those providers, we certainly want to bring them on board. But I think by far the bigger impact is the unlocking, I'll call it, of these other use cases of payment and operations, both of which are theoretically equal to treatments in HIPAA. People often refer to TPO, and we've really only done the T. We really do expect the payment and operations to be a major unlock for the TEFCA ecosystem, as well as continuing to unlock patient access, which has been an ongoing challenge. And you know, actually, Stephen, one of the things I was going to react to that you said earlier was that there wasn't a business case for some of these types of data exchange. I would, at the risk of sounding controversial, I would say that's not the case. There absolutely is a business case for it. The problem has been there have been competing business cases for maintaining a status quo and not necessarily allowing the access to occur. And so it's that tension between those competing business cases that the federal government, frankly, has been generating rule after rule, including information blocking, including clarification around a patient's right of access, that are all trying to cut through, on the patient front specifically, the lack of progress.
And I think what we're going to see is, while the initial TEFCA go-live is going to be voluntary, that over time, over the course of the next couple of years, there will be more and more incentives for people to exchange data over the new TEFCA framework, coming from CMS, from CDC, potentially from NIH, from all the federal agencies which are really working together to try to get this up and running and incentivize its use.
Yeah, and the the 1,000-pound gorilla, so to speak, is CMS, and we've already seen them signaling that they are planning to incentivize TEFCA participation. I think requiring it it will eventually come, but by that time, but by the time requirements come, they'll probably no longer be necessary, is kind of the irony. But I do expect there to be incentives that'll really be what moves the needle here over the next couple of years in terms of truly having TEFCA realize the original vision of the legislation, which was to have a single on-ramp for providers, for other participants in the healthcare ecosystem, into this data, the data universe.
And I think we wanted to talk about sort of the technical underpinnings of TEFCA. As we said, the initial TEFCA go-live will be built on the chassis of existing exchanges. It'll be mostly document-based exchange of continuity of care documents using IHE protocols, really what we're seeing today in the existing exchange but on the networks and the frameworks. But there is a FHIR roadmap that we are involved in advancing in concert with the RCE, and it's really quite exciting because there is a plan for the next version of the technical requirements for TEFCA to include more FHIR-based exchange, and the anticipation is that we will see that come out in the coming year.
Yeah, and it's something that's worth noting and pausing on for a moment, because there's been a lot of comment and activity in the public sphere about FHIR specifically as it relates to TEFCA. I think there's a few things that people are not recognizing or appreciating. One is the sheer volume of activity that occurs today using what we can fairly call legacy transaction standards. Trying to do something completely new as opposed to riding some of those existing rails to an extent, I think would have been a little foolish for the first step of TEFCA in terms of getting it up and running at minimal investment from key players like the EHR vendors who already have developed the support for these transactions, in order to really get that critical mass of providers who are the key to the whole thing, right? Ultimately, most people are trying to get access into the provider's data for various reasons. The payer data is certainly out there as well, but at the end of the day, the value of TEFCA comes from having a base of installed providers. And so in order to get that base up and running, there was a need to go with technology that was already out there, already existed, and you could simply layer a new contractual and governance framework on top of it, as opposed to changing multiple things at once. Now, all of that said, everyone recognized from early on that we would not want to stop there. The framework is designed to be flexible in terms of different technologies, and in fact, there is a lot of discussion underway in terms of how the transactions that occur between the qualified health information networks can use FHIR going forward. We're not permitted, we have learned, to tell you much about those discussions, but they are underway. And there's been a published roadmap that is out there publicly that I believe outlines something like Q1 of 2024. That may be a little optimistic, given that QHINs themselves are likely to go live at the very end of Q4 here this year. However, it's reasonable in terms of expectations that pretty quickly ONC is going to move towards ensuring that FHIR is a core part of the TEFCA ecosystem. Now, all of that said, what we're talking about here also is, and I know there's a little bit of inside baseball maybe, but the transactions that we're talking about are those that are between the qualified health information networks. The vast majority of the participants and the attendees here at this conference are not qualified health information networks, obviously. So how you participate, what you see as your technological impact, is wholly dependent on what your QHIN supports. And in fact, our participants will be able to engage with us via FHIR from day one. In fact, that's how we expect them all virtually to interact with us. We've developed some capabilities in case we need to do some other things, but ultimately our customers today interact with us using FHIR APIs, and they will continue to do so with the QHIN.
One of the concerns that we've heard in the press, and there have been a number of publications that have been put out, had to do with a piece of the ONC's HTI-1 proposed rule that came out earlier this year, where the ONC and the federal government generally, as we said, is looking for opportunities to incentivize TEFCA. And what they proposed in their rule was that if you're doing TEFCA exchange, that creates a bit of a safe harbor in terms of information blocking, that you can say, I'm not information blocking because I'm doing TEFCA exchange. And there were some people who observed that there was a concern there because we still want to encourage and require exchange using other methodologies. So it's not as if just signing up for TEFCA really should necessarily, get you out of all of the requirements of information sharing that are out there. And I sit on the ONC's Health IT Advisory Committee, and we had a number of conversations about this. And I think whoever wrote that part of the proposed rule wasn't thinking about some of the potential downstream impacts of that. And there's been a lot of public feedback. We're waiting now for the final rule, the final ONC's HTI-1 rule, which Mickey told us last week is likely to come out still this quarter, possibly next month, and hopefully we will be able to see how that got ironed out. But I don't think that there's any risk that ONC is going to put information blocking, on the rails in lieu of TEFCA. I think that those are going to go forward together.
Yeah, and for those who maybe weren't as familiar with the specific proposal and some of the unforeseen consequences, and there were unforeseen consequences, the concern that has been raised by multiple parties is that the way that it was written could allow an organization to say, hang on, I'm participating in TEFCA, therefore I do not have to provide the FHIR APIs for Smart on FHIR via OAuth that is widespread in its use today for getting information out of the EHRs for patient purposes, and in fact that was a legitimate concern. There was a real I think oversight in the proposed rule that I know until the actual final rule comes out, people will still have that concern a little bit in the back of their minds. But having known Mickey and known the folks at ONC for many years, I'm confident that they're going to close that loophole and will likely pull back from the proposal and find other ways to incentivize TEFCA.
Absolutely. So we've talked a bit about the fact that TEFCA is going to start with two exchange purposes, the treatment purpose and the individual access services or patient access. That the anticipation is that we've seen draft what they call standard operating procedures for how TEFCA is going to support payment, healthcare operations, public health exchange, and there's still anticipation of supporting public benefits determination as well. So there are a number of additional use cases that, again, we have not seen really flourish on the existing exchange framework that we have today. There have been published initial drafts of the payment, healthcare operations, SOPs. There have been, I don't think there has been a published public health draft yet.
I think that's right. There's been some work group activity around public health, and that's one that I think there's a lot of careful thought that needs to occur. There's a lot of considerations around the legal rights to the data, who has what rights, which particular public health agencies are involved, how does CDC play a role in directly participating and or incentivizing, and then also just the reality of the state of the technology that public health agencies are using. They're not well-funded agencies generally, and they have technology that shows that.
But I think we anticipate that the payment and healthcare operations will be the next major use cases that TEFCA takes on. And of course, it's a great opportunity to streamline the exchange that's going on today, mostly between payers and providers, but also since patients will be in the mix with individual access services, it'll also provide yet another avenue for patients to get their claims data from their payers and exchange data in a more multi-part process.
Yeah, I think there's a lot of exciting things that folks are waiting for, in particular around payment and operations. I know when I moved over full-time to Care Equality, having been involved in its founding in very early 2015. And not too long after that, folks from payers became involved in my steering committee and advisory council. And now 8 years later, they're still there. They're still not able to really get a whole lot of benefit from it, frankly. But that's where I think we really will see a major unlock there from the TEFCA ecosystem.
So did we want to take some questions, or a few folks here in the audience?
Yeah, absolutely.
Yeah,
better than just speaking into the void, I suppose. If folks have any questions, we could keep talking. We could talk about TEFCA for a long time.
Absolutely. But if there are folks who have questions, we'd be happy to entertain them.
Hi, thanks for the time. So I'm Catherine McAtee. I'm from Matrix Health. Early on in the conversation, you had mentioned, Stephen, a comment around the patient access use case hasn't gotten off the ground well. Can you talk a little bit more about that? Is it more on the use case side, the technology side, or maybe even just patient adoption and willingness to share their data?
So patient access is near and dear to my heart. I'm a family doctor. I was part of the team that stood up the very first EHR tethered patient portal 22 years ago. So I've been involved in the patient access space for a long time, and really portals have been the primary patient access play for the last 20 years. And they work pretty well, but there are some real challenges with portals in that it's connection into one EHR, one health system, actually. Even if you have multiple health systems on the same EHR, you can't integrate that data. So some years back, some really smart people figured out how to use FHIR to query for patient data from health systems. And Apple Health, I think, really pioneered that, but Common Health and others have come along behind that. And now there is fairly extensive opportunity for patients to query for their data from providers, one at a time, using a FHIR-based query. But even so, that has not really moved the needle a lot. I think it's still difficult for patients to collect all their data from all of their provider organizations to create a unified picture, to basically have a copy of all of their medical records. And part of that, as Dave intimated earlier, is because there are still people hoarding data, trying to hoard their patients, trying to keep patients connected to a health system, to a vendor, et cetera. I think the idea with patient access within TEFCA is really the hope that a patient will be able to authenticate once, to be able to send a query to all providers and payers, all those entities that maintain their data, and then to be able to collect that data into an app of their choice in a way that it can then be, deduplicated, normalized, and maintained, and then utilized. I mean, if you use Apple Health today, there's a handful of apps in the App Store that can use that data to provide services, medication reminders, what have you. But I think that's the vision, and it's really a vision that ONC and HHS generally has been promulgating for a long time, that patient access will really unlock a lot of value, will allow us to address a lot of the burden that patients have in moving around and accessing care from different providers, and really being able to access valuable care for them at the lowest cost, the most convenience, et cetera. So I don't know if I got at the core of your question. Dave may want to add to that.
Yeah, I would add a little bit to that. I think there have been challenges in a few different fronts. So, I think early on in the first iteration of personal health record apps, were really focused, I think, in a noble way on giving patients access to their data. And I think about that, and that's good for a certain subset of patients who truly need get their data and kind of assimilate it all and pour over it and maybe provide it on to a provider who have really complex care needs. Most of us, though, that's not how we interact with the banking system or with other aspects of our lives via apps. We do workflows in little short chunks that enable us to advance whatever it is we're trying to do. So, yeah, every once in a while I'll log into my bank account just to see what the balance is. But usually, I don't want to just look at my balance. I want to actually do something. I want to deposit a check. I want to transfer between accounts. I want to pay a bill. I want to do something. And that, I think, is the piece that has been missing. And some of that is simply it wasn't part of what the initial universe of apps did. Then, as people started to have the idea of, hey, you know what, we should maybe do this a little bit differently, they started running into the data challenges that Stephen was describing. And it is challenging to be able to handle the ability to query into networks like TEFCA and to be able to do Smart on Fire via OAuth and maybe do some customized connections in other ways. And that's exactly where, circling all the way back around, like somebody like Health Gorilla can play a role for consumer apps in having the data platform there for you to do that, tools to help you manage those connections. And I think there's a role for a lot of different players there, including us and platforms like us, including a bunch of different apps. And all together, I think once we actually have the ability to tap into a large enough set of data, which is coming, is arguably there now, we just need to sort of combine a couple different methods of doing that access. Now we start to get some really exciting possibilities of enabling those workflow steps I was alluding to for patients.
Thank you.
Another point about patient access. Oh, Charlie, go ahead.
Thanks, Stephen. Charlie Harp, Clinical Architecture. Could it also, part of the problem be with the patient access being that the data that we collect tends to be a little bit overwhelming too?
That's absolutely true. I think that patients can be quickly overwhelmed by the amount of data that's out there, and I think it's important that when patients do collect their data, that the services offer them the ability to organize that, understand it, make sure that it's, as you know well, Charlie, deduplicated and normalized and in a format that allows them to really see the insights that they need and to make decisions with it. It's interesting. You mentioned the banking system as a metaphor. We all understand dollars and cents, right? But not everybody understands blood pressure and sodium and and all the other things that you need to keep track of with health data.
Oh, and that feeds into my earlier point that as a patient, you shouldn't necessarily have to. I mean, sure, HIPAA gives me the right of access, and I absolutely should have the ability to go just look at my data and decide for myself, do my own research, if you will, on what is going on with my record. But at the same time, really what we're after is that the patient doesn't have to understand all of that stuff, that people are providing tools that allow the patient to play the right role at the right time in the healthcare ecosystem, as opposed to just sort of collecting their records and trying to understand them. Now, all of that said, somebody does in fact have to understand the data, and even for providers it's hard. So that's a whole different conversation about the value of tools to deduplicate, normalize, etc.
So to finish up, why don't you turn off, see if that helps.
I didn't actually. That would.
Okay. So just to finish up on TEFCA, and especially the individual access services piece of that, this is something that we're really very excited about supporting at Health Gorilla. When we go live, we're going to be one of the only QHINs that both responds to IAS queries, but also helps to initiate those queries. And Avery Haller and I are going to be back up on the stage tomorrow at 12:45 talking about individual access services in more detail.
Charlie has one more question.
Of TEFCA and the QHINs, with everything that's happening in CDC and kind of some of the restructuring and the modernization, that there's a tremendous opportunity for public health once we have the utility of QHINs moving patient data from a biosurveillance perspective.
Oh, there's no question. I mean, biosurveillance is but one of the many public health use cases that I think we're going to see. My understanding is that there is going to be money for the states and the regional public health organizations to connect up to TEFCA, that there will be incentives likely coming for providers to use the TEFCA infrastructure for some of the public health exchange that we do today. A lot of that exchange, as we learned through the pandemic, is very challenging, very expensive, very inefficient, and there are a lot of opportunities. And so that's definitely one of the real pluses for TEFCA.
Yeah, agreed. I think it's going to be a use case that is certainly very important to policymakers and government at all levels, including the federal government. And you will see. I mean, we already see. I mentioned earlier there's work group activity. There's a lot that's being done behind the scenes to bring the public health community at all of its levels up to the level of understanding and agreement on how to implement TEFCA. But that is being done. It is going to get there, and I think it is going to be powerful for public health once it's there.